Assalamu alaikum. Good evening, everyone. This is the final pharmacology flashcards session, and this is an extremely high yield one. The reason why, because we have here 15 to 20 questions that came on the last two exams. So let's start right away. The first question is asking about a patient that had a snake bite, and they were asking what is the indication of an antivenom in this case. If you think the answer is vomiting, then you are right. So let's recap quickly the indications of antivenom. In the next slide, we have the systemic symptoms and the extensive local symptoms. Nausea and vomiting comes first because it came on the last 2 or 3 diets. Severe headache, ophthalmoplegia, any patient with diplopia, think about antivenom. Seizures, bleeding, DIC, shock, not transient hypotension, dark urine, and the extensive local symptoms. Last diet, the progressive swelling came on the form of compartment syndrome. So this is very high yield. Coagulopathy, we just discussed with the systemic symptoms, and painful lymphadenopathy near bite site. So just remember compartment syndrome and nausea and vomiting as an indications of starting antivenom immediately. Of course, this follows ABC. Next question is a 33-year-old man with long-term cannabis use. He came with persistent vomiting. So they were asking what is the best medication for this patient persistent vomiting. So this is a case of CHS, cannabis hyperemesis syndrome, and if you find among the choices IM haloperidol, choose IM haloperidol. And the same question came with different choices, and the answer was topical capsaicin. Very true. So the syndromes of nausea and vomiting that we need to be familiar with are chemotherapy, nausea and vomiting. How can we manage this one? Ondansetron, excellent. Pregnancy, nausea and vomiting. Vitamin B6, motion sickness. Anything ends with zine. Migraine, we all good with migraine, nausea and vomiting. Metoclopramide. Gastroparesis related nausea. This is actually an MRCP question, and here we give the prokinetic metoclopramide and erythromycin. This is very high yield for MRCP, not for MRChem. Radiation induced, same like chemotherapy induced, ondansetron before radiation, and the weighted syndrome THS cannabinoid hyperemesis syndrome, haloperidol or capsaicin topically. Okay, so next slide is a patient who was found disoriented outside a bar. I think you already know the question and know also the answer. Agitated, tremor, ataxic. He is tachycardic, hypercapnic, and the patient has. Sorry, he is tachycardic and tachypnic. Okay, there is no tachypnea in the case. Okay, so he is tachycardic and hypoglycemic. The patient also has nystagmus, excellent, vernix encephalopathy. How can you manage this patient? That was actually the question. How would you manage this patient hypoglycemia? If you just mention that we need to start thiamine before glucose, then that's absolutely right. Of course, this follows ABC, and we shouldn't delay the labs, blah, 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 IV thiamine. Okay, so the role of thiamine as an emergency treatment, there is 3 famous or common scenarios. that you may find thiamine as the best to start following ABC. So number one, vernix, we just discussed, and number two, hyperemesis gravidarum, and of course, refeeding syndrome in malnutrition patients. Okay, so the next question is another nausea and vomiting, tinnitus, diaphoresis, agitation. Patient is tachypnic, tachycardic. Okay, here is the patient who is tachypnic and tachycardic and feverish. And on ABG, this patient has metabolic acidosis. And if you find metabolic acidosis, immediately ask me what is the anion gap, or I will ask you what is the anion gap for this patient. This patient anion gap is high. So high anion gap metabolic acidosis plus tinnitus. Think of aspirin toxicity. How would you manage this patient? Following ABC, we need to correct this patient electrolytes. And how can you excrete aspirin in the urine? We need to okay, there was charcoal. Aspirin is a charcoal responsive, so we correct electrolytes, and after after resuscitation of the patient, we need to give sodium bicarb to alkalinize the urine. If the patient has resistant acidosis, how would you manage this patient? Dialysis. Excellent. Next case is an elderly patient with heart failure on medication. He came with nausea and vomiting, confusion, dizziness, yellow-green vision. Peak to wave on ACG, referring to hyperkalemia. How would you manage this patient? So what's your diagnosis? This patient is taking heart failure medications. Is it beta blocker? I don't think so. Is it CCBs? I don't think so. What else you would think about? Digoxin toxicity, excellent. How would you manage this patient? ABC. And what would you give for digoxin toxicity? So ABC, we collect electrolytes. Again, charcoal. Digoxin is charcoal responsive. I am not sure about that. I think yes. I mean, this is not a high yield point for digoxin, but the high yield point for digoxin is we need to give FAB fragments. Digoxin specific Fab fragments for detoxification of the digoxin. Of course, we treat the arrhythmias. Next case is again an elderly patient. He came to you confused, drowsy. The patient is also heart failure patient on medications. What do you think is this ECG showing? If you think so if you think this is the sagging effect of digoxin, then you are absolutely right. This is the chronic users of digoxin. Oh, this patient has irregular baseline, no P wave, irregular RR intervals. This is AF with the sagging effect of digoxin, which that you can see with chronic users, not acute toxicities. So this is the digoxin effect. Chronic use, ECG changes only, and has nothing to do with the toxicity. But toxicity can be chronic or acute. The acute comes with GI symptoms. The chronic comes with neurological symptoms. Of course, this needs to be managed immediately if acute and if there is electrolyte imbalance. Next case is a patient came with reduced level of consciousness, agitation, dry mouth, dilated pupils. Okay, I think now you got the case. Tachycardic, hypotensive, and he's a known case of psychiatric illness. So what is this? Dry mouth, dilated pupils. If you're thinking this is anticholinergic symptoms, then This is a big clue for the answer. Let's see the ECG. The ECG shows what comes to your, like, what is flashing in your eyes. Prolonged QRS. Excellent. Prolonged QRS, not QT, prolonged QRS. More than 100 milliseconds. So this is TCA toxicity. You have neuro symptoms, you have anticholinergic symptoms, you have alpha blocking symptoms, the hypotension, and the ECG shows prolonged QRS TCA toxicity. How would you manage? To protect the patient heart, you need to give immediately calcium gluconate or calcium chloride. So the planned toxicity is started to come in the exams recently, and recently I mean like in the last 5 years. And the most famous is digitalis-like toxicity, and the plant name is foxglove. How would you manage this patient? Same Fab fragments, organophosphate-like toxicity. The poison or the plant name is poison hemlock. Anticholinergic toxicity, completely opposite, and the plant name is datura, the Jameson weed, the atropine-like effect. The treatment for digitalis, of course, weak ABC, electrolytes correction, and Fab fragments, atropine for the poison hemlock, and for the anticholinergic toxicity, this is an extremely high yield one. We give the physostigmine. So let's cover the three plants here quickly. So we have a history of plant ingestion, nausea, vomiting, dizziness, confusion, bradycardia, arrhythmia. So this is usually will be foxglove. We treat as digitalis toxicity. The next one is patient comes with wild plant ingestion, excessive salivation, muscle weakness, fasciculation, bradycardia, respiratory compromise. What do you think? Organophosphate like finger dumbbells. Okay, how would you manage this patient? Same like we discussed organophosphate in the first session. ABC, atropine, and pralidoxin for the nicotinic symptoms. Third one is a patient with altered mental status, hot dry skin, dilated pupils, anticholinergic symptoms. So this is anticholinergic plants, which is where atropine comes from. The toxicity, how would you manage? ABC and physostigmine. So let's quickly cover the next three questions. A patient who had sore throat fever, and recently he was taking carbimazole. This is one of the very high yield questions that comes on and off. I think every exam this question will appear. This is a case of query agranulocytosis, and we need to do CBC to rule out neutropenia. If we have neutropenia, then we need to hospitalize the patient and give cultures and send cultures and start IV antibiotics immediately. If neutropenia is confirmed, this is opposite this case, which is a patient who started recently in a chemotherapy session. So this is febrile neutropenia. Without waiting for the labs, just start IV antibiotics, tazocin, piperacillin, tazobactam. The last question, I hope this is the last question. So this is a patient who had prolonged QT, and you were asking what is the medication responsible for the prolonged QT. Haloperidol. The prolonged QT medications are very high yield. Don't forget fluoroquinolones from the antibiotics, haloperidol, antipsychotics, antiemetics, ondansetron, and antiarrhythmic, the class 1A antiarrhythmic. Thank you, and see you in the next session.